So, good evening, ladies and gentlemen. Welcome to the 14th episode of the Kerala Society of Ophthalmic Surgeons online journal club. I am Dr. Smita Narayanan, the editor of the Kerala Journal of Ophthalmology, and I am a professor at the Regional Institute of Ophthalmology, Trivandrum. With me today are Dr. Arya, who is a junior consultant at Amardeep Eye Care, Kollam, Dr. Ashok Natraj, who is a senior consultant at the Retina Services of Precise Eye Care, Trivandrum, Dr. Biju John, who is the professor and head of Department of Ophthalmology at Government Medical College, Kollam, and Dr. Sheshadri Mahajan, who is a senior consultant in Retina at Sudha Hospital, Hyderabad. Tonight, the article of discussion, Article 4 discussion, are actually two randomized controlled trials, the Kestrel and the Kite. And this article deals with the 52-week results from the two phase 3 pivotal trials of brolucizumab for diabetic macular edema. So I request Dr. Arya to provide us a summary of these two studies. Dr. Arya.
Thank you so much, ma'am. Let me share my screen.
Yes.
Is my screen visible, ma'am?
Yes, it is visible. Make it full screen, please.
Is it okay now, ma'am?
Yes, perfect.
Okay. Thank you so much, Smita ma'am and KSOS for this opportunity. So, good evening all. The article for journal for discussion today is Kestrel and Kite, 52-week results from two phase 3 pivotal trials of brolucizumab for the management of diabetic macular edema. So, before that, let us discuss in brief about diabetic macular edema as well as what has happened so far in the management of diabetic macular edema. We all know diabetic macular edema is one of the main causes for vision loss in patients with diabetes mellitus. And DME occurs in 3 to 6% of diabetics aged 18 years or older. Okay. So now coming to the pathogenesis of diabetic macular edema, the first and foremost event is loss of pericytes, which leads to microaneurysm formation, dilatation of capillaries, which in turn results in breakdown of blood-retinal barrier, which leads on to fluid leakage into the extracellular space and further disruption of the macular structure as well as function. The management of diabetic macular edema consists of control of blood sugar levels as well as other associated systemic conditions like hypertension, dyslipidemia, blood hemoglobin levels, renal parameters, as well as specific therapy to reduce the diabetic macular edema. So what are the specific treatment options? These include retinal laser in the form of focal laser, grid laser, modified grid laser, subthreshold micropulse laser therapy. And the second one is intravitreal antivascular endothelial growth factors, and corticosteroids in the form of peribulbar injection, intravitreal injections, as well as intravitreal implants. Now, it was noticed that conventional macular laser photocoagulation is associated with scar enlargement over time, decreased retinal sensitivity, subretinal fibrosis, choroidal neovascularization, and vision loss from direct foveal burns. So, laser usually have visual gains which have been modest and hence erase the need for alternative treatment options. Now, let us see why anti-VEGF agents in diabetic macular edema. These are the reasons. It is observed that there is increased VEGF levels in vitreous in diabetic patients, and VEGF has an important role in the pathogenesis of diabetic macular edema as well as diabetic retinopathy progression. And the VEGF levels correlates with the severity of retinopathy as well as macular leakage. And the VEGF levels were significantly found to be increased in diabetic macular edema patients than age-related macular degeneration. So, following phase 3 trials like Restore and Rise and Ride with ranibizumab and Vivid Vista with aflibercept, the anti-VEGF agents has replaced conventional laser photocoagulation as the principal management of diabetic macular edema. But what are the drawbacks of anti-VEGF agents? Usually, intensive treatment is required to dry the macula and achieve optimal treatment outcome. The anti-VEGF agents usually have transient effects and often need repeated injections, which exposes the patient to the risk of an invasive procedure. The mean number of injections in a year being high with an average of 9 according to protocol T. This often leads to high rates of non-compliance under treatment for diabetic macular edema and in turn lower visual gains. Thus came the need for treatment options to improve the response rate and to reduce the treatment burden with a lower frequency of injection and monitoring visits for the patients while maintaining the visual function in patients with TME. Here comes the relevance of one of the newer anti-VEGF agents, brolucizumab, which is a single-chain antibody fragment that has high affinity for all VEGF molecules. Its lower molecular weight of 26 kilodaltons compared to 147 kilodaltons with bevacizumab and 48 kilodaltons with ranibizumab and 95 to 115 kilodaltons with aflibercept. It enables the delivery of more drug per injection compared with other available anti-VEGF agents, and often offers the potential for more effective tissue penetration as well as increased duration of action. Now coming to the study proper, 52-week results from 2 phase 3 pivotal trials of brolucizumab for diabetic macular edema, just conducted by David M. Brown et al. The study design, it is a double-masked 100-week multi-center randomized controlled trial. The primary 52-week outcomes were collected between July 2018 and November 2020. The purpose of the study was to compare the efficacy as well as safety of brolucizumab with aflibercept in patients with diabetic macular edema. So what are the inclusion criteria? The subjects were more than or equal to 18 years of age with type 1 or type 2 diabetes mellitus and glycated hemoglobin levels less than or equal to 10%, and BCVA score between 78 and 23 letters using early treatment diabetic retinopathy study visual acuity charts at initial testing distance of 4 meters at screening as well as baseline. Those with central involved diabetic macular edema with central subfield thickness of more than or equal to 320 microns on spectral domain OCT at screening. And only one eye per subject was included in this study. Those with active PDR were excluded from the study, and those who received intraocular or periocular steroids in 6 months prior to baseline, as well as those who received prior anti-VEGF therapy at any time during the study were excluded. Now coming to the randomization, in Kestrel group, total 566 eyes were randomized as 190 eyes in brolucizumab 3 mg group, 189 eyes in 6 mg group, and 187 eyes in aflibercept 2 mg group. In Kite group, 360 eyes were randomized as 179 eyes in brolucizumab 6 mg group and 181 in aflibercept 2 mg group. Now, coming to the treatment protocol, in the brolucizumab arm, 5 loading doses were given every 6 weekly interval, as in week 0, week 6, week 12, week 18, and 24. This 5 loading doses were followed by intravitreal injection every 12 weekly. But an option was provided to adjust the dose to every 8 weeks for the remainder of the study period if any disease activity was detected at any of the assessment visits, like more than or equal to 5-letter lows in BCVA with increase in central subfield thickness compared with the subject's disease status at week 28. Coming to the aflibercept arm, 5 monthly loading doses were given, as in week 0, 4, 8, 12, and 16, which was followed by a fixed 8-weekly regimen. All the subjects in both the groups underwent disease activity assessment by the masked investigator at weeks 32, 36, and 48 in the first year, and an 8-week treatment need was identified if the disease activity, as priorly described, was detected at any of these visits. The primary outcome of the study was mean BCVA change from baseline at week 52, and the key secondary endpoint was BCVA change from baseline averaged over period week 40 through week 52, and others were changes from baseline at each follow-up visit in BCVA, including more than or equal to 15-letter gain or loss, status of subretinal fluid as well as intraretinal fluid, and percentage of subjects with CSFT less than 280 microns at week 52, and change in ETDRS diabetic retinopathy severity scale score from baseline. In order to assess the effect on visual acuity as well as anatomical outcome, the following study assessments were done. BCVA was evaluated with ETDRS chart at an initial testing distance of 4 meters every 4 weekly, anatomical landmarks, anatomical markers on STOCT every 4 weeks, and ETDRS DRS score based on color fundus photography at screening week 28 as well as week 52. The vascular leakage evaluation was done by fundus fluorescein angiography at screening week 28 as well as week 52. Now, about the baseline characteristic, baseline demographic as well as disease characters were generally similar across both the groups in both the trials. There were more males than females in both the group in Kite as well as Kestrel study. The mean baseline BCVA in Kite study was slightly higher for the brolucizumab 6 mg arm versus aflibercept arm. And almost all subjects, about 100% subjects showed presence of retinal fluid, IRF as well as SRF at baseline in both IRF at baseline in Kite as well as Kestrel, whereas SRF was present in 31 to 37% of subjects across all treatment arms. Coming to the results, about the first parameter, best corrected visual acuity at week 52, brolucizumab 6 mg was found non-inferior with a margin of 4 letters to aflibercept 2 mg in mean change in BCVA from baseline, with Kestrel group having 9.2 letter gains in brolucizumab group versus 10.5 letters in aflibercept group, and Kite group having 10.6 letter gain in brolucizumab 6 mg group versus 9.4 letters in aflibercept 2 mg group. And coming to the proportion of subjects who gained more than or equal to 15 letters from baseline in BCVA, in the Kestrel group at B52, in Kestrel group, the brolucizumab 3 mg had 34.2%, brolucizumab 6 mg with 37, and aflibercept 2 mg with 39%, while in Kite group, there was a significant high proportion in brolucizumab 6 mg group with 46.4% and aflibercept 2 mg having only 37.6%. And the non-inferiority of brolucizumab 6 mg to aflibercept 2 mg was met for the first key secondary endpoint. There was an average change from baseline in BCVA over period week 40 through week 52 in both the trials. Now coming to the second parameter, central subfield thickness, no differences were observed between the brolucizumab as well as aflibercept arms at each post-baseline visit in Kestrel. But greater reductions were consistently observed for the brolucizumab 6 mg arm in Kite, with the exception of week 36. At week 52 in Kestrel, the mean change from baseline in CSFT was there was an estimated difference of 5 microns between brolucizumab 6 mg and aflibercept group, while it was only 4 microns between brolucizumab 3 mg and aflibercept group. In Kite group, the mean estimate of change from baseline in CSFT was more in the brolucizumab 6 mg group compared to the aflibercept 2 mg group. While seeing the proportion of patients who achieved CSFT less than 280 microns at week 32, in the brolucizumab 3 mg as well as 6 mg group, it was almost comparable with a greater lead compared to aflibercept 2 mg group, which are only 29.4% at 32 weeks in Kestrel group. In Kite group, at 32 weeks, brolucizumab had 48% subjects and aflibercept had 30% subjects with CSFT less than 280. And at the end of 52 weeks, the brolucizumab 3 mg had 48.4% and 6 mg with 54% and aflibercept 2 mg with 40.1% in Kestrel. And Kite study, there was superiority of brolucizumab 6 mg with 57.5% and aflibercept 2 mg with 41.4%. About the retinal fluid, both SRF and IRF, compared with baseline, a lower proportion of subjects were observed with retinal fluid for brolucizumab compared with aflibercept at week 32 as well as week 52 in both the studies. About the dosing maintenance, subjects were maintained on 12-weekly interval dosage after loading to 52 weeks, where in Kestrel group, brolucizumab 3 mg had 47.4% and 6 mg had 55.1%. And in Kite group, brolucizumab 6 mg had 50%. And the subjects or those who remained on 12-weekly regimen at week 52, within those who successfully completed the first 12-weekly cycle at week 36 were 87% and 87.6% in 3 mg and 6 mg group respectively. And in Kite study, it was 95.1% in brolucizumab 6 mg group. And the median number of active injections up to week 52 were 7 in the brolucizumab group and 9 in the aflibercept group. About the diabetic retinopathy severity score, a clinically relevant improvement from baseline in the ETDRS diabetic retinopathy severity scale score was observed in all the treatment arms at week 52. And in pooled Kestrel and Kite analysis, non-inferiority of brolucizumab 6 mg compared with aflibercept 2 mg in relation to those who achieved more than 2-step improvement in DRSS at week 52 were established. About the adverse effects, the incidence of ocular serious adverse effect events were 3.7% in rolizumab 3 mg arm, while it was only 1.1% in rolizumab 6 mg arm, and 2.1% with aflibercept 2 mg in Kestrel group. And it was 2.2% in rolizumab 6 mg group and 1.7% with aflibercept 2 mg group in the Kite study. The overall risk of intraocular inflammation, retinal vasculitis, and retinal vascular occlusion were higher in the brolucizumab treated eyes compared with aflibercept treated eyes. So the study concluded the brolucizumab 52-week results in Kestrel and Kite studies demonstrated clinically meaningful visual acuity gains as well as excellent anatomical improvements with an overall favorable benefit-risk profile. Hence, brolucizumab could provide an additional therapeutic option in diabetic macular edema management that reduces the burden on patients, physicians, as well as the healthcare system. Thank you.
Thank you very much, Arya. Actually, you have given us broken down the studies, both of these studies, into real bite-sized, understandable things. I think you have summarized it very well. Thank you very much. Now I request Dr. Ashok Natraj, who is a senior consultant at the Precise Eye Hospital, Trivandrum, to give us a critical appraisal of how well or how badly these studies were conducted and how they could have improved. Dr. Ashok Natraj.
Okay. Yeah. Thank you, madam. So basically, I'll just give you an overview of what exactly is happening. So this study is all about diabetic macular edema and its treatment. So, Dr. Arya had said we have a lot of treatments, but, in simple terms, you keep only one thing in mind. For diabetic macular edema, now the treatment is intravitreal injection. It can be an anti-VEGF agent or it can be a steroid. So let's go straight. We are talking about anti-VEGF agent. So why this particular study is there? Now they have introduced a new drug called brolucizumab. It is called Paginax, and they are trying to say that this Paginax is superior to other existing drugs in the market, and they are trying to say that this drug really works for diabetic macular edema. Now, as Dr. Arya was saying, for Paginax, it's a very small molecule. So a lot of molecules can be packed for the same molecular weight. So a greater concentration of drug can be injected, and it has got a potent VEGF binding property and will cause a potent anti-VEGF effect, which can last for a longer time. So this is the basic thing. Now, what is the data we have? We have the RISE, RIDE, RESTORE study where we talked about treatment of diabetic macular edema with ranibizumab. Now we have the VIVID and VISTA studies where we talk about treatment of diabetic macular edema with aflibercept. And now the new molecule has come called Paginax, where we talk about treatment of diabetic macular edema with brolucizumab. Now, a very interesting point in this particular study is normally in VIVID, VISTA, etc., they have never compared one anti-VEGF drug with another one. You can see that very clearly. If you see VIVID and VISTA, they have compared frequency of dosing. That is, 4 weekly dosing with 8 weekly dosing with laser in VIVID and VISTA. When they are trying to say that, aflibercept is a very good drug for DME. And if you look at RISE, RIDE, RESTORE, etc., they talk about different dosage of ranibizumab with laser observation, etc., And only in the DRCR net studies, that is an independent group which compares different drugs. Only in those DRCR net studies that we usually see this kind of comparison between two drugs. Now, it is very interesting to note that the company here itself, as a matter of whatever it is trying to say in its own study, comparing it with its competitor, aflibercept, and trying to say that it is as good or better than aflibercept. So that is something very, very interesting as far as a study that a company, phase 3 study, a company itself is conducting for its launch of its new molecule. Now the study design is okay. You have seen the study design and other things in this particular study is pakka because it is done by professionals. It is done to push the study in, and get it approved by FDA. And now the drug is approved by FDA in the US, and that means it's a very, very well-designed study. Now, what we are trying to do in this particular thing is, what are they trying to push? What are they trying to say without saying? What are they trying to push? That what do you say? Jugaad, you say, in this thing. What are they trying to do, to make sure, this drug looks really superior to other drugs? So basically, this study is to say that, this particular drug is better or even equal to aflibercept, which is its main competitor in the management of diabetic macular edema. Okay. Now let us go from each part. You have the methods of the study. Study design is over. Now let us look at the study population. Now, if you see the study population, what is the exclusion criteria? Now they have excluded patients with proliferative diabetic retinopathy. Now you see, if a patient has got diabetic macular edema with proliferative diabetic retinopathy, will this particular drug work? Will the same results hold good? That we don't know. That is one thing. And second thing is, they have excluded patients who have had previous intraocular anti-VEGF injection and previous injection of dexamethasone in the past 6 months. So these study populations are very naive population. They are not this kind of chronic macular edema which doesn't resolve. These are all very naive population who has not undergone any anti-VEGF therapy. And if at all they have undergone some intravitreal steroids, it is more than 6 months back. Now let us go back to Vivid and Vista trials. Vivid and Vista trials. That is diabetic macular edema studies using aflibercept. Now there, see the same advantages of that particular study. Obviously, that study showed that aflibercept worked in diabetic macular edema. So in Vivid and Vista trial, people who have got previous anti-VEGF injections, they also maintain the same effect as treatment-naive patients using aflibercept in the Vivid and Vista trial. So that portion has been omitted in this particular study, and that is a matter of how you take it to see whether aflibercept is better or brolucizumab is better, or you can say that that particular issue is not addressed in this particular study. That is one thing. And now let us go to randomization. Obviously, randomization should be okay. Other things should be okay. And endpoints of the study is like, primary endpoint was mean best correct visuality change from baseline at week 52. So that is also okay. Secondary endpoints you have said. Now, another important thing is, see, why can't they say the study is, why can't you do a superiority study? See, when they're very sure this brolucizumab molecule is better than your existing, whatever, what is aflibercept, why are they not conducting a superiority study? Why are they conducting a non-inferiority study? You understand? So the basic point is, they actually, they want to play it really safe. Okay, so what is the aim of publishing this phase 3 trial? The aim of publishing this phase 3 trial is to get it approved by FDA. FDA is a Food and Drug Administration, that agency in the US which approves all these anti-VEGF agents. So for FDA to approve a particular drug, they just need a positive non-inferiority study only. They don't need a superiority study. So the company will never take a risk. They will just do a non-inferiority study and say that it is as good as any existing drug. So you please approve our drug also. And that is why this study is done as a non-inferiority trial. Okay, so these are the other things. And now let us come to the statistical analysis and other things. Now there are some terms here, which I would like to just say so that you get an understanding of what is happening. Now there is something called as a full analysis set. Okay, so full analysis set is a statistician, when he has to get data out of a particular set of samples, etc., he can use something called as an intention to treat set. Intention to treat set means it is the total number of patients or whatever who are proposed to be included in the study. Okay. These may not include patients who have lost to follow up. This may include patients also who have been lost to follow up or who has not even received any treatment. So that is a very, very vague term. Now, this full analysis set means it involves all the patients, excepting those patients who have not really complied with this particular study. So that is very important. And you have something called as a safety set also. See, safety set means a population who have undergone at least one injection. So if you do analysis only in that particular set, will you get safety data of this particular group of patients? So safety set was used for safety analysis, and full analysis set was used for analysis of data for this particular study. And ANOVA model. See, when you have two interventions and you have two outcomes, you take the mean out of that outcome, and when you see that those two outcomes are different, now you want to find out whether actually these outcomes are different. Okay, suppose there are two sets of students. One set of students have already studied the portions before only. Teacher is teaching the portion for the first time. Another set of students are there. They have not seen the portions at all. Now, after the coaching is over, the teacher asks questions. Now, the people who have studied the portions even before, they will answer the questions better. So, just because those people have answered the question better doesn't mean that these set of students are better. So, there are certain factors which, even when there is a difference, will confound the outcome. So, that is why we are doing all these tests. When there are only 2 sets of samples, you use the pair t-test or whatever. When you have more than 2 sets of samples, you use the ANOVA test. Now you have the null hypothesis and alternative hypothesis. When you find that there is no difference in mean, you call it null hypothesis. You say there is no difference. When there is actually a difference, you call it as the ANOVA model and you find out. And you have called something called as the F test. Okay, so this F test really will tell you whether the intergroup or the intragroup variability is actually there, and actually there is a difference between these 2 sets. So that is what has been mentioned. Then there is something called as the least square mean difference. There is something term called as a least square mean difference. Okay. So whenever you are comparing 2 variables, you do what is called as a regression analysis to find out the relationship between these 2 variables. Okay. So what you're trying to do, you plot all the data that you have, all the variables like time and CME. Central foveal thickness, you plot all that and you plot a line. Okay. Now this least square mean difference analysis, what it does is, it tries to put in all the data into a meaningful curve so that, you can get some information out of it. Like a scatter diagram means the data are all scattered. You're not getting any meaningful diagram output out of that. But using this kind of analysis, you can put with this particular data into a particular trend or a line, so that it fits into the regression analysis and you can get some data out of it. Okay. Then there is something called as the LOCF imputation. That means even when the person has actually not come, suppose a person is not really something related to loss of follow-up. Suppose there are 10 visits. The 4th visit he doesn't come, but he comes in the 5th visit. You can fill in the blanks by looking at the trend. The person has not really come and you have not measured, but you can just fill in the blanks by looking at the trend. So that has also been done in this particular study. And the sample size calculation for the non-inferiority. So this is a non-inferiority study. This is not a superiority study. See, like an alternate hypothesis, the hypothesis that we are saying is that one study is not inferior to the other. That is all. It is not superiority study. And if you see, the power of the study is 90%. Usually the power of the study is 80% normally. The power of the study is 90%. So importance is, as the power of the study increases, the sample size that we are calculating increases, keeps on increasing. Because, we want to get a better data, and the sample size here has been calculated as 160 eyes per arm. So that you get a proper non-inferiority study. So this is the basis of whatever statistical analysis that has been done. Okay, so Dr. Sheshadri, what is your opinion about anti-VEGF and DME? And based on the study, what do you think is the role of brolucizumab according to the study in our current scenario? Not able to hear. Not able to hear. Not able to hear.
Yeah. So very well summarized by Dr. Arya. It's a very lengthy study, and she has put up precise statistical requirements of the study in the presentation. And you have also summarized, so my job becomes much easier. The crux of the study is very simple. This is a non-inferiority study, which they have done with the aflibercept and with the brolucizumab. And these are 2 studies, and these are phase 3. And basically, these are mass studies. It is very important to know. And these are randomized and active control studies. These are very, very important things. Many sites were involved throughout the globe. And as far as the Kite study was involved, it involves the Asian population. And in India, 5 sites were selected, and so that study result more correlates with our population also. This is to add to what Dr. Ashok has already commented on. And as he has summarized that brolucizumab, the drug molecular weight is very less, so the penetration and the effect is very good based on the previous studies which have been done in cases of age-related macular degeneration. And aflibercept has been studied well before in various other studies for diabetic macular edema. So what they are looking at this is this drug, if it is this is non-inferior to the aflibercept as compared to the diabetic macular edema, vision improvement and resolution of the macular edema. So the question remains in this study is, what is the dose? So Kestrel study has studied 6 milligram, 3 milligram, while Kite study is 6 milligram brolucizumab. They are studied with the 2 milligram of aflibercept. The second thing is the purpose of the main study will be the number of dosing. How many doses? See, the burden of the diabetic macular edema is a chronic disease, and the number of injections is a question. So how to reduce the number of injections? Because it will reduce the disease, the patient number of visits and patient compliance, as well as it will reduce the complication rate. So if you go ahead with brolucizumab, they are looking at how many less number of injections you would require as compared to aflibercept. When suppose the non-inferiority is confirmed by this study, so eventually patient will adhere to the number of injections. So what they have done is here they are looking at less number of injections with brolucizumab as compared to aflibercept, and the second thing they are looking at the interval between the two injections. So if you look at brolucizumab, they have tried with 6 weekly. Aflibercept we give it 4 weekly as a loading phase, and here the loading is also brolucizumab 5 injections they have given. 6 weekly, 5 injections. So longer the loading duration also is long. So what happens, the visual acuity, which is at the end of 52 weeks or over a period of time, will be maintained much more better, which has been proved in previous studies where the loading dose phase remains for a longer period. So here 6 weekly plus 5 loading doses, and then they have shifted choice to either 12 weekly or 8 weekly based on what is the disease activity after those loading injections. So now here again the number of injections, how they are reducing is, suppose after loading doses, if you disease activity means how much the drop in the vision is there, or where the subretinal retinal fluid is present or not there. Based on that, the investigator has taken a call whether to go ahead with 12 weekly dosing or 8 weekly dosing. If the disease activity fits into it, then they will shift to 12 weekly. So they have found that those shifting 12, almost 50% patients there, 12 weekly. So that means the number of injections is further less. And if the disease activity is present, then 8 weekly will be there. So that is what they have tried to do is the number of injections which can be less. So in this, after loading doses, 12 weekly injections, almost 50% patients will require, they will be maintaining a good vision and reduction in the macular edema with 12 weekly doses. And how do you know that? So suppose first 12 weekly loading, 6th injection you are given, and he does well, then he's likely to do well with 12 weekly injections further till 52 weeks. That is the main idea of this study is there. However, if you see the power of the study, coming to the statistics, Dr. Ashok has already summarized. And it's a very large multicentric study. So obviously the statistical analysis and the parameters they have used is appropriate to the study. What I feel is with this study, the main advantage is, if you see what are the advantages of the study, this is the first time they have compared to direct two anti-VEGFs like brolucizumab as well as aflibercept, and then it's a mass study. And then they have used a central reading center to check for the parameters like reduction in the macular edema based on the OCT, and how much is the diabetic background, diabetic retinopathy changes which have reduced because of giving anti-VEGF. So this is done through a central reading center. That is also an advantage of this study. And here, what they have tried to do is the disadvantages are also obviously there because this is not head-to-head study. The two drugs are not compared head-to-head because the dosing interval is different. And the second thing in this study is what you see, because of I have a feeling that might be the COVID also, because this study was done around before ending of 2019. So by that time, the COVID must have come, and then maybe European countries or some of the Asian countries would have started some effect on the follow-up. So that is also a possibility in this study. The other things is this study gives you a gross view about very specific drug dosage of brolucizumab. That is 3 milligram is not going to be useful. That is very clear cut. And Kite study is more applicable to us, and it has shown that the intraocular inflammation, which was a major concern as compared to brolucizumab, because brolucizumab has shown to cause retinal vasculitis and intraocular inflammation in previous studies with age-related macular degeneration. So they have found that the incidence in Kite study is as comparable to the aflibercept. So that is what the study says. So anything more, Dr.
Yes,
Metro, would you like to add?
Shishan. Yes. Now, I would like to ask Dr. Biju, we have these baseline characteristics. And these baseline characteristics are very important in determining, what exactly the study means in the ground. You have a set of population to whom this particular drug has been applied, and these results have come out. Now, in your real life, when you're applying, it is these kind of patients that are going to respond similarly to this particular drug. So, Dr. Biju John, sir, do you have any comments about the baseline characteristics, something interesting that you found?
Yeah. Okay, first of all, I would like to thank Dr. Smita for giving me this opportunity. And Dr. Arya had made a good presentation, well summarized, and good summaries from Dr. Ashok and Dr. Mahajan also. Yes, I'll just straight away go to the Dr. Ashok's question. Rightly pointed out, definitely there will be a say in the baseline characteristic, which type of population, it is applied. For example, I think even right in the study, as has been pointed out by Dr. Mahajan also, there is a difference that you can see between the Kestrel and Kite, because it belong to two different types of population. Because the Kite, because the brolucizumab, in treatment of diabetic macular edema, the main worrying factor for us is the number of times we need to actually repeat the injection. The transient effect of the drug. So we are always on the lookout of a drug which can actually give us a durable effect. And that is why drugs like brolucizumab simply excite sites. So if it works out, then it could be the answer to our problem, provided the cost is also coming down. But then comes the question of some of these side effects, like the retinal vasculitis and retinal vascular occlusion, which even though are very minimal, when they occur, it is it's a concern, because they can result in serious loss of vision. For example, there is even 2 cases of retinal vascular occlusion in the 3 milligram Kestrel group, 1 case in the 6 milligram Kestrel group, again 1 case in the Kite group. So that is definitely there, and that is a concern. But again, thankfully, when you look at the patient characteristic, it is a comforting factor that when it belongs to our set of population, these side effects are much less. For example, there has been no retinal case of no retinal vasculitis in the Kite study. There was 1 case of retinal vascular occlusion, but again, it's considerably less than that of the other population. But again, that brings to a slight suspicion. Is there any other factors which are also involved, which is responsible for this sort of a difference? Because the number is also, largely different. I think there are about double the number in the Kestrel study. But hopefully, maybe we can take comfort from these things that probably in our set of population, the brolucizumab will be a safer drug. And again, coming to Dr. Ashok's question, generally when we have a diabetic macular edema treatment-naive patient, we all have our set of preference. We generally start with one drug which generally is ranibizumab or a biosimilar ranibizumab now, unless the patient is pseudophakic or something. And there are certain characteristics, for example, some biomarkers, which will probably shift our priority to some other drug, like a steroid or an aflibercept, like, for example, a chronic macular edema with large cystoid spaces, then large submacular detachments, some hyperreflectivity dots like that, recalcitrant macular edema. So these are some of the other factors which we would be considering when selecting the drug also.
Yes, certain, as Dr. Biju has really summarized the basic characteristic well, but I would like to point 1 or 2 points here. Now, if you see, we talk about the Indian population. See, I mean, they don't form much of a group in this particular study. So, as Dr. Biju said, definitely the Indian population, we don't see these complications of vasculitis and occlusions as reported in the Western population. And whether this can be really extrapolated to the Indian population as a study number, as far as Indian population is concerned, is very less in comparison to the European population, which is the maximum. And second thing is, this is majority of the patients were having type 2 diabetes. That is one thing. And the time of DME diagnosis, time since DME diagnosis is less than 1 year. I mean, it's not like, you have this chronic CMEs coming in. And if you look at the baseline visual acuity, it is much better than, you have your vivid, vista, etc., etc. You deal with the patients with better visual acuity. And if you look at the amount of patients with having subretinal fluid, that is very, very less. Mostly it is, intraretinal fluid. So you have this, rise and ride trial, which says that patients with better visual acuity, serous macular detachment, they do better with treatment with anti-VEGF. So here we have a group of patients whose, the amount of SR of the study population itself, the majority of the patients, they don't have a serous macular detachment. And what we have been said throughout the study is the amazing drying effect of this particular drug. If you see, when you compare it with aflibercept, if you use brolucizumab, the drying effect is more. And one more thing you have to keep in mind is drying effect doesn't mean more visual acuity. You have seen with steroids also. When you have a chronic macular edema, you give steroids, the macular edema goes off, but vision doesn't really improve. So those are some of the things. And another important thing here is, majority of the patients are having moderate non-proliferative diabetic retinopathy. So this is a group of population that we are dealing as far as this study is concerned. Now, one important point, I would like to ask Dr. Sheshadri is see, you have this Kestrel and Kite study. Now, as Dr. Sheshadri pointed out, we know this, 3 milligram brolucizumab is not working. Okay, it has really failed the test. And only 6 milligram brolucizumab can be compared with 2 milligram aflibercept. Now, why Kite study, you see the effect of brolucizumab 6 milligram is so much. And in the Kestrel study, 6 milligram is not giving you much effect. I mean, why do you think? I mean, do you have any speculation about that? It's very interesting, to see. Because 6 milligram brolucizumab is giving amazing results in the Kite study. And in the Kestrel study, it is mediocre. Why?
With very less side effects also. None of those adverse are there.
So why it is like that? At least side effects okay. Why it is? I don't know the answer. I'm just speculating. I just want your inputs. That's all. Sheshadri sir.
You are muted, sir.
You're muted, Sheshadri.
Yeah.
You're muted.
Yeah. Only difference which I see is the explanation which I see is mostly the difference in the population. Beyond that, I'm not able to at this point of time to come to any conclusion, because there is as Dr. Ashok has said, there is a difference between what you see between the Kestrel and Kite study. There is a difference. You notice it.
Biju sir, any ideas? Biju sir, any ideas regarding this?
No. I was also wondering, is there a question of any? I was just wondering whether any bias is involved, but that is not unlikely because the study is so, methodology is so perfect, so it's unlikely. But then how come?
No, actually,
another point of concern about that.
Actually, I also.
Yeah, in the talking about the side effects. Yeah, talking about those side effects in the Hack and Harriet study. Even after they had a post-market, post-hoc analysis, then there were more side effects. They actually found that there were actually more. So that would probably apply here also. So that even after the aftermarket studies also would have to be taken, and probably side effect might take some more time to maybe kick in. So that's also there.
There is an additional thing is because since we have Harrier and Hock study results and the vasculitis or intraocular inflammation is we already know about it because of the study. So maybe this time the investigators or they may be more cautious at this point of time. So they might have treated it very early. That could be the reason that we are not seeing number of so many retinal vascular. This could be one of the reasons that we see the difference as compared to the previous study which was done for the AMD.
No, actually, when I looked into it, I was really surprised why they should have. Then when I looked at the number of injections, you see, if you look at the number of injections, median number of injections for brolucizumab is 7 and aflibercept is 9. You can see that. And that is one thing they say, because, you have to take 9 injections of aflibercept to get the same effect of 7 injections of brolucizumab. So that is one thing you say. And if you look at the Kite results, see, they are saying 7 active injections percentage, 8 active injections, 9 active injections. Okay, you have you have it in page number 166 in your article, if you see. So one interesting thing, if you see, is that in the Kite study, okay, at least 61% have taken 8 injections, even though say median is only 7. At least 93% have undergone 7 injections. Okay, and 61% have taken at least 8 injections. Okay, and the percentage in the Kestrel study is only 57%.
Yes, so that's what. So that is the thing.
Point
so
is, I think
57% only could be maintained. I mean, they took
49%. It's only 49%. 6 milligram is only 49%.
Yeah. So rest of the 50%.
Obviously, it is more number of injections, correct?
Yeah.
No, it just shows that if you take more injections, your macular edema is going to become better and you're going to gain more vision. Correct. And that's why I think, Kite was doing better than the other one, because you can see their data only shows they have conveniently put it in small letters.
Yeah.
And one more thing, see, regarding the dosing, that also, I wanted to take it up. See, in case of aflibercept, you give loading dose at 4 weeks, 5 injections, correct? Every month, 5 injections. For brolucizumab, every 6 weeks, 5 injections. Okay. And then you have the maintenance dose. For brolucizumab, it is 12 weeks. And for aflibercept, it is 8 weeks. Okay. Now, if you look at it, brolucizumab has got the luxury to reduce it from 12 weeks to 8 weeks if it doesn't work.
Yeah.
You see, but aflibercept doesn't have the luxury. Always you have to take it 8 weeks. Okay, and you see the Vivid and Vista trial. Okay, you had a group that was taking every 4 weeks, and you had another group taking 8 weeks. This is for aflibercept in DME.
Yes.
Obviously, 4-week group was doing much better than the 8-week group.
So
see, you take 2 drugs. You take 2 drugs, you give all the leeway to brolucizumab just to prove that, that is better. And when it comes to aflibercept, they should take only 8 weeks. They cannot reduce it beyond 8 weeks. That flexibility is not there. And if you look at the 2-year study, that is the 100-week follow-up has also come up for this brolucizumab. This is 52-week. The 100-week phase 3 also has come up. And there, in the Kite study, they could even extend it by 16 weeks. This 12 weeks could be extended even up to 16 weeks. Okay, but aflibercept doesn't have that luxury. So aflibercept can never be taken more than once in 2 months. You have to take every 8 weeks. You have to take whether you like it or not. So and brolucizumab you can extend. You can say that you can take less injections. What is the meaning?
So exactly, this is not a head-to-head one. It's not head-to-head.
See, that is very important. That is very important.
So last 3 months, if you see, last 3 months, I mean 40 weeks to 52 weeks, which they say.
Yeah.
So there is the catch. There the things are changing actually. Where the aflibercept is the fixed one. However, this has got a flexibility. So that is a limitation of this study.
That is a very big limitation. That's
because
what I feel.
The number of injection, if you see that they are saying that 9 as compared to the 7 injections, it's a very two numbers, although they are significant for the patient point of view. But as far as the study, when it is not head to head, to say really it has happened 7 to 9 is a questionable one.
And another important point is, yes, Viju sir, please.
No, I was just telling that the focus is more on finding out the durability, how long it can be extended, how long the patient can be kept, injected.
No. See, if you look at protocol T study, in protocol T study, they had compared aflibercept and your Avastin and other, and Lucentis, whatever they have compared. See, in patients having vision less than 6/12 in the first year, Aflibercept did really well. After 1 year, that results didn't last. So just because, see, and when a patient is concerned, you have to give him the best vision. Whether it's one, see, after 2 years, vision is the same. So why should I give Aflibercept? That should not be your way of thinking, See, in the first year, if one drug can give the best of results, in the first year, you should give that drug so that, he gets the maximum benefit. In the same way, if Aflibercept 4 weeks, is going to give you better results as proved by Vivid and Vista, why are you withholding it? Why can't you see in patients who are not doing well with 8 weeks Aflibercept? Why in the study did they not decrease it to 4 weeks? When they have solid evidence from the Vivid and Vista trial, which says that, every 4-week Aflibercept is better than 8 weeks Aflibercept. That they should do, no? That is a moral responsibility. And to say that one thing doesn't work, just, you tie the hands of one person. The other person, you don't tie the hands and you ask them to fight. Who will win, obviously?
Yeah, but then I think
that is what,
considering the backdrop of the real life situation, because we hardly managed to keep these patients on these drugs because of their, you get a lot of non-compliance. Nobody, even the loading dose. Are you just going by the loading dose in your real life scenario? You give 3 or 4 loading dose like this, or you just, what is your usual pattern?
No. See, I have had patients, with Eylea who take this 5 injection course fully. And I have seen patients, even after the macular edema goes off, they take another shot, their vision improves, even without macular edema. See, this loading dose 5 injection is very, 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 very effective. The point is, you should give the best treatment to the patient. At least you should tell them that this is a treatment. Whether they take it or not is a different thing.
Yeah, because
but
I think
in this context, we are talking about the study where they're getting everything free. There is no point. There is no question of non-compliance. They are given bus charge, airfare. Everything is set.
No.
We are talking about a study setting.
Yeah, the study as far as it is okay, but when you try to sort of apply it to the real life scenario, especially now my situation, it is totally unthinkable. Somehow this loading dose, we hardly get any patient where we can give loading dose even.
The study has also shown that even after first injection within 4 weeks, whether you take Aflibercept or Brolucizumab, there is a substantial increase. If you see the curve, in the post 4 weeks itself, you start getting good results. 4 weeks. So that is.
And see, the study has shown one more trend in protocol I. If you see people who don't respond at 12 weeks, they don't do well at all. Yes. After 3 injections, if they don't really respond, they don't do well at all. Now you see here also, after that between 40 and 52 weeks, whatever that time is there, who are compliant to that 3-month follow-up, they do really well in the study also, if you see. Yeah. See, these are all trends, that are all reflected across anti-VEGFs. It is nothing, which is very special to this particular drug or anything like that. And if you see the vasculitis and vein occlusions, vascular occlusions are particular to this particular drug called Brolucizumab. See, even though adverse events are comparable, but no patients with Aflibercept ever develop vasculitis.
Yeah, true. That is one.
No patient with they never develop vasculitis. Just by saying that side effects are comparable, and that is not correct. Correct in the sense that they still have vasculitis and vascular occlusions. So just to say, statistically they are not significant. I don't think that is a great way of going about it. So that's what.
So I would like to know from your personal experience, all 3 of you, from your personal experience, would you give Brolucizumab for any instance, any special instance in diabetic macular edema?
Yeah, Biju sir, this question is for you.
Yeah, not as a first line drug at present.
Okay.
Yeah, but maybe in any case where you get a recalcitrant edema which is not responding to any of the other things, and if you get a patient without where you can predict that there is absolutely no sign of inflammation, probably I would consider. But then I'm a little concerned about this vasculitis and all these things. And probably I think because there is another kid down the line, one drug called Faricimab. which is having almost the same effect, and even can even extend up to 16 weeks without any of the side effects. So probably I think I would just hold it and wait for that one. By the time till now, I will probably manage with the ranibizumab and aflibercept rather than going for brolucizumab.
Dr.
Shesha, is a real opinion.
No, frankly, we restrict ourselves to this study. If you say, then definitely I would suggest a center involving macular edema where the vision is dropped down. Then I would definitely advise first injection is definite, because the trend you see with both the injections, the first 4 weeks gives excellent improvement in the vision. However, if you see the loading doses, definitely number of injections as compared to aflibercept is less. So I would, if the patient is, and if you see the cost, ultimately the cost of 5 injections is roughly almost similar to aflibercept. So this is a better penetrating drug available. And although intraocular inflammation is a concern, I would definitely suggest patient to go with brolucizumab based on this study, because it's a non-inferiority study. However, continuing for a long, after through the 40 weeks and 52 weeks, there will be a, I'm not sure it will be as good as aflibercept. So definitely, as far as the loading doses in Indian scenarios where most of the patients, you find very less number of patients adhering to so much rigid criteria which are used in the study. Usually they would come out definitely for 3 loading doses, and they might take, they might jump, or they might take another opinion or something. But then first injection definitely, and if possible 5 could definitely. This study shows that it's a non-inferior. So based on the study, yes, definitely I would go at this point of time, because the Kite study, although not all the population was related to Indian population, however, it has Indian population, and I would definitely at least for 5. And the first 3, if you see the first intraocular inflammation or the retinal vasculitis, they notice around, I think, if I'm not wrong, some 99 days or something earliest they detected is. So definitely, I would go ahead with the brolucizumab in the initial phase at least.
Dr. Ashok?
Yeah, and I just want to make 2 points. Whenever you talk about brolucizumab, the chance of inflammation doesn't come with 1 injection. It comes with repeated injections.
Yes.
So the important point here is, with the loading dose, you give 1
Yes.
injection, 2 injection, 3 injections. Is there an increased risk of intraocular inflammation with that? And in DME, we are dealing with patients with 6/9, 6/12 vision, maybe one eyes also. So we don't know. And diabetic retinopathy with PDR, this study doesn't address also. That is one thing. And one advantage is, brolucizumab always has a superior drying effect when compared to other anti-VEGF agents. So in cases, which really doesn't, when other drugs don't work, I think, you can really try brolucizumab, because with brolucizumab, I've seen patients whose macular edema really vanishes in DME. I've got one patient who have had multiple ileas, everything, but one shot of brolucizumab, their macular edema is gone. So these are the 2 concerns. I think you have to balance it off in your day-to-day practice and see what is more important, and then decide. That's what I feel.
Dr. Arya? I'm sorry. Dr. Arya, would you like to comment? Arya, unmute yourself. Okay. Okay, continue, Dr. Ashok. I don't think Dr. Arya is coming.
Yeah. So I think, to summarize, brolucizumab is an excellent drug in DME. And in conclusion, more than 50% of the patients could be maintained at a 12-week or 3-month therapy of brolucizumab. So the frequency of usage of drug, etc., are much better when compared to aflibercept. But they have tried to put some things down the carpet. They have tried to show that, it is much better than aflibercept by hiding certain things which we had discussed, by, just doing little things to make things more convincing. And I think, that is one thing that is bad. Otherwise, I think it's a next. I think that's it.
So I think we come to the end of our program, and we had a very nice, very discussion where we discussed threadbare about the study. Thank you, Dr. Ashok. Thank you, Dr. Sheshadri. And thank you very much, Dr. Biju John. And Arya, I think you've done a wonderful job. Thank you very much for participating.
Thank you. Thank you,
Thank you.
KSOS. Thank you, Dr. Ashok. Thank you, ma'am. Thank you, sir. Thank you.
Yeah, thank you. Good night.
Yeah.
Thank you very much. Really
Thank
enjoyed
you.
interacting with
Good
all of
night.
you. Thank you. Bye.